Michelle Stevens. I'm a professor in English and Latino and Caribbean Studies in the School of Arts and Sciences in Rutgers, New Brunswick. I'm a scholar of the literature and culture of the African diaspora, and I'm also a psychoanalyst and a scholar of race. I'm also the founding and executive director of the Institute for the Study of Global Racial Justice, the ISGRJ, which is the institute that received the grant from the Robert Wood Johnson Foundation that is sponsoring and supporting this study that we've called Black Bodies, Black Health. So I thought we'd start the conversation today thinking a little bit about the history of race, in the sense of how does the history of racial formation actually impact how we think or are unable to think about race today.
So I was going to talk a little bit about thinking about Blackness and health in particular, and taking that back into the pre-modern era and the field that I study in, which is called pre-modern critical race studies. So I think there are two main threads that I think are really important in thinking about Black bodies and Black health in historical perspective. The first one is the idea of Blackness as a sign of otherness. So if you imagine Europe and the Americas of the early modern world as increasingly thinking of itself as a white society, that a concept of whiteness is emerging as an identifier, Blackness is being associated with the idea that good health and good medicine is a scarce resource, that access to good health and good medicine is a privilege rather than a right, and that the appearance of Blackness is triggering that sense that we're now very familiar with, that we're in competition for limited resources. And there's a fear that comes with that. And it's that fear that informs nativist agendas and racist policies that affect our medical system and our health system as well. Finally, and for me, this has been a really fruitful location for studying race. Blackness is represented as both a problem and an uncorrectable problem. There's a popular saying from this time period. It's known as "to wash the Ethiop." It's a saying. It's kind of like the leopard cannot change its spots. The idea is, you can't wash the Blackness off the body of an Ethiopian person. It's a really popular saying that comes up across all kinds of texts, but what it says is what's really interesting to me. It means that not only is Blackness understood as fundamentally a flaw or a problem, but also that it's something that there is no remedy for, medical or otherwise. And nevertheless, the person whose body we're talking about, this body that is touched by Blackness, is somehow also at fault for that problem.
As I get further into these social determinants of health, and instead of, or in addition to just measuring inequity, but trying to get at some of the root cause in my research and my work, and then develop strategies to try to deal with them. And the more I do that over the last several years, the more I develop more of an appreciation for history and how we got to where we are. And at the early stages of the pandemic, I started to think even more about these social determinants, because I and other health equity researchers, prior to the data becoming available, suspected that some of the same structural factors that have been in place, that have been kept in place, that enable the persistence of health inequities would probably show up in terms of COVID risk and inequities. Racial differences in health, they were present at the very inception of health records being kept in the United States up until and through the Civil War in the mid-1800s, right, in 1861 specifically. And physicians at the time debated whether the already well-known racial disparities in health were due to, on one hand, biology, simply because Blacks were genetically inferior, or social factors, because many Blacks were enslaved and all Blacks lived in a society steeped in white supremacy, one in which Black minds, souls, and spirits just didn't matter as much. And at the time, the debate was deeply rooted in politics. So back then, science was driven by politics. And that sounds a bit familiar. It should to us.
Yesterday, almost as if the New York Times knew we were meeting today, they ran a piece with the headline, "Black Americans Face Disparities in Long COVID Treatment." Now, as we all know, this is one of a long list of racial disparities, which include, as was just mentioned by Charles, disparities in COVID infection, hospitalization, as well as death. And we could add a longer list of health-related disparities, in addition to economic disparities in income and wealth. I've written at great length about racial disparities in educational achievement and attainment. There are, as many of the participants here today know, considerable disparities in the criminal justice system, and the list goes on. As a philosopher, I spent a lot of time digesting scholarship and knowledge about legacies of race and racism, and then trying to make certain kinds of analytical distinctions to sort of capture what I observed. And one general observation that I think I can offer is that race has been reified in a system of beliefs and discourses about the explanation of racial disparities generally, and also racial disparities in health in particular. And I think already the first two comments that we've had have supported this. Scientists who do empirical work, they're very cautious about saying that X causes Y. I mean, they don't really typically like to talk that way. Most of it is in terms of correlation. And the good social scientists, I think, are careful about this. Now, I don't think anybody wants to say that people's choices don't matter when we're thinking about some of these health outcomes. But what we do want to emphasize is that these circumstances, the kinds of circumstances that Charles pointed to and other people will no doubt point to, are very important when we study these outcomes. And another thing that people don't say enough about is the interaction between these circumstances and people's choices. That's very important to think about. Like, what kind of choices am I going to make if I live in a food desert in Detroit, right? When there's no Whole Foods on the corner, right? What choice am I going to make if I'm working 3 jobs? I'm using public transportation. I have to deal with childcare, homework, and et cetera. And I don't have a lot of time to prepare, a certain kind of meal. I think it's really important for us to appreciate that interaction as well here.
Physical disability studies teaches us that able-bodiedness and health are not identical. This one kind of make that statement again, right? That able-bodiedness and health are not identical, which would make us suspicious of the self-evident value of health. Now I'll just kind of focus my comments on that second comment more precisely. So health might sometimes be seen as an unquestioned and self-evident, objective of medical intervention and cultural work. But disability studies argues and encourages us to see cure with a healthy skepticism, right? To imagine that fixing something, making something whole or improved might also have other drawbacks or issues. It actually suggests that woundedness, vulnerability, and anomaly are inescapable, but also really generative aspects of lived experience. And if this is the case, what might Black healthiness look like when it is strategically decoupled from the ideology of ability, right? What might we gain by aligning healthiness with certain types or configurations of pain, loss, or trauma? And actually then, how can we dream a world without health disparities and not at the same time presume and advance an ableism that would punish all frailty and insecurity. And that's really kind of where the heart of my work has been generated, is by thinking about the kind of ironic affordances of vulnerability, of loss.
When social scientists sometimes create studies in which they're looking for causality, and they create like variables, independent and dependent variables, part of what I'm familiar from a historical perspective of doing is basically questioning the very variables that you've brought into the study, so if you're sort of studying it by race and assigning race, well, if those are such freighted categories with social constructions of ability, disability, pathology, non-pathology, whatever that is, it really requires a stop and think moment where you ask yourself, what might I be bringing to my own study that is the sort of current culmination of buried discourses and constructions related to race?
My work, what I find is that oftentimes we take a lot of categories for granted, right? So I loved Keith's statement about, able-bodiedness and health are not the same thing, right? These are really important points, right? One of the things that my interlocutors often do for me is make me question the categories that I enter the field with, right? When we think about race, we think about gender, we think about sexuality, we think about what, these lofty terms like vulnerability and resilience, right? They challenge all of these terms because obviously a lot of this terminology about what life should be and how our lives should be and how we should experience life are all rooted in these capitalist agendas and ideologies of what a good life is, right? And so in Puerto Rico particularly, I find that, my interlocutors often challenge this question of like resiliency, right? Resiliency is not something that we want to be, it's something that we have to be, right? So when you're experiencing various forms of colonization, racism being positioned within, so Puerto Ricans, there's race in Puerto Rico. So here's another sort of complication, right? Puerto Ricans at all are racialized as Black against the United States, right? But within Puerto Rico, there are white Puerto Ricans, there are non-Black Puerto Ricans, right? And so these discourses of race and racialization themselves and how non-US centric identities then get reimagined into what are the health possibilities for people once they come here, right? So dealing with diaspora populations really challenges a lot of the ways that we think about Blackness, that we think about how we form racialized identities, but also how colonization and imperialism give the possibilities for how race is formed.
This question of kind of the environments themselves and how do we think about structural determinants of health as a kind of causal vector into health disparities, right? And something Derek said really stuck with me, right? That we think about that race has become reified as the explanation of racial disparities, right? And precisely what Melinda was talking about is that process. And so I think a lot about how do these kind of ideas about race and these conflicts over resources get crystallized in political moments to form social policy in ways that carry forward to then generate inequalities that new policy solutions, which are going to be reflective of this racialized context, right, then try and solve. So we think about contemporary policing, which is something I work on a lot. And I'm mostly a quantitative researcher, but we think about the sort of inequities in exposure to violence writ large in our society, but police violence in particular. And when we divorce that from the context of hundreds of years of segregation, hundreds of years of disenfranchisement and dispossession and exploitation, right, we kind of miss the meso-level causes that generate community inequalities that then feed back into the supposed policy problems that generate violent solutions like policing, right? So if the social problem of interest is crime, right, it's incumbent on our models and our theories to sort of recognize the ways in which pre-existing social processes and independent dynamics feed into those processes and then structure the response. I guess what I'm trying to say here is that there's the institutions themselves, right, become these kind of vessels that can transmit racial politics across time in really fascinating ways. Like a question for me, thinking about contemporary policing in America, I also study the child welfare system and family separation through foster care, is why do we have the policy systems we have? We have to kind of denaturalize what we think of as wellness. We have to denaturalize what we think of as health. We have to denaturalize what we think of as safety in some ways, right? Because these are constructs that emerge out of particular policy formations that have distinctly racialized histories.